Thank you for the invitation. And I have no financial interest to declare. So I've been asked to talk about the adnexae. Adnexae is Latin for appendages, and here we're talking about the appendages of the uterus, which are basically the ovaries, the fallopian tubes, and their supporting structures. Mostly, the disease is diagnosed on frontline imaging modalities such as ultrasound or CT, so that we know when the patient comes for MRI that they already have the presence of an adnexal mass. So what is being asked of the MRI? The questions are, is it benign or malignant? If it's inflammatory, is it a surgical emergency? And if it's malignant, what stage is it? So the role of MRI for adnexal masses is really in the characterization of the mass and in the staging. So in the next 20 minutes or so, that's what I'm going to talk about, characterization and staging of adnexal masses. And under characterization, we're going to deal with some of the techniques that we can use, normal anatomy, inflammatory masses, the revised WHO classification, and the features of benign and malignant disease. So the techniques. Avis has dealt with some of them with regard to the uterus, and it's pretty similar with regard to the adnexae. So in addition to the standard morphological techniques of T1 and T2 weighted imaging, we have gadolinium enhanced imaging, in which we give an extrinsic contrast agent, which is uptaken by tissues which have high perfusion, and it alters the T1 relaxation of the water in that tissue. So it's really the water we're looking at, and it's important to remember that, not the gadolinium directly. And the tissue shows high or shortened T1 relaxation. So in comparison, a tissue such as an endometrial cancer, which is poorly perfused, might show as a negative contrast. In other cases, it might be that the pathology itself takes up the contrast and shows as a shortened T1 relaxation in compared to the background normal tissue. And we can model this by looking at the rate of uptake of that contrast agent into various compartments, such as the plasma or the extracellular compartment, and how quickly it washes from one compartment to another, and work out rate constants for that. And that gives us values that are numerical for things like permeability, wash-in, wash-out, and so on. A simpler way of contrast enhancement, as it were, is using the intrinsic property of the tissue, which is diffusion-weighted imaging. And again, we've heard a lot about this. It looks at the free motion of water within tissues, which is restricted in more cellularly dense tissues, which means that as we increase the diffusion weighting of our sequence, in a freely diffusing tissue, we get a diffusing away of the signal, whereas in a cellularly dense tissue, such as a tumor, the signal is retained. So at a high B value, as Avis has so elegantly shown you, a tumor shows a high signal intensity, but on the ADC map, the rate of change of that signal intensity or the slope of that line is much lower, so it appears as darker. But we can quantify that, and that's what's important. So, the normal anatomy of the appendages. The ovaries are the most important structure, and basically, the ovaries are a source of female gametes. The oocytes, which reside within the follicles, are at various stages of development, and they're surrounded by these granulosa cells. And as the follicles develop into secondary follicles, they get enclosed within thecal sacs. The oocyte is discharged monthly, as you know, and that leads to the formation of a corpus luteum under normal hormonal influences. Therefore, the ovaries on T2 weighted imaging can be seen as multicystic structures with these oocytes within their follicles. They're in a variable position in the pelvis, and they have low signal intensity stroma. There will be cyclical changes as the follicles develop into secondary follicles, and they are atrophic pre-puberty or after the menopause, or if the patient is taking the oral contraceptive pill. And here's just some normal ovaries and atrophic ovaries on the pill. So it's really important to note whether the patient is on any kind of hormonal manipulation during the time of the scan. Beware, I say, of calling polycystic ovaries. This is a condition that is well described. You've got normal-sized follicles in a ring, multiple normal-sized follicles in a ring around the ovaries, but actually it's quite a meaningless diagnosis out of the context of what is called polycystic ovary syndrome, because it has implications for the patient, and without knowing those clinical implications, it can be a devastating diagnosis. So it's good to be wary when producing a report saying polycystic ovaries. Corpus luteal cysts can have varying appearances, and if you're in doubt, scan the patient at a different time of her menstrual cycle to be sure. So, inflammatory masses. The most important thing about inflammatory masses is that the patient is acutely unwell. That is really the giveaway. The types of pathologies that we're dealing with are torsion, tubo-ovarian abscess, pelvic inflammatory disease and hydrosalpinx, ectopic pregnancy, which I won't talk about because it's a big topic in itself, and endometrioma. Ovarian torsion presents, as I said, with an acutely unwell patient. Usually, the patient has had an enlarged ovary because of a mass or other reasons, such as fertility induction or tubal ligation. Most patients are young. They get stromal edema and internal hemorrhage within the ovary. It's really important because the sequelae of these can be devastating. You can get ovarian infarction and lose the ovary. On MR, you see this classical kind of world appearance of the ovarian pedicle, and that is really pathognomonic of an ovarian torsion. A tubo-ovarian abscess similarly presents with fever, elevated white blood count, and vaginal discharge. Again, you see a heterogeneous enlarged edematous ovary, and the presence of air is pathognomonic. On the gadolinium enhanced scan, you get in this inflammatory mass with enhancement and heterogeneous restricted diffusion on the ADC map. In pelvic inflammatory disease, in addition to this edematous ovary, you get a hydrosalpinx or dilation of the tube. Again, the patient is clinically unwell. They're usually febrile with pain. There is a history often of instrumentation of intrauterine contraceptive device, and the sequelae can be devastating if you don't diagnose this correctly, because it can lead to infertility or even malignancy if it's chronic. But you see here this dilated tube with the fluid levels in it, which are classical. In my neck of the woods, which is mainly in a cancer hospital, the diagnosis of an inflammatory mass is usually an infected lymphocyst. So you can see in this patient here, she'd had a lymphadenectomy, obviously that's the clue, and you've got a painful mass in the groin, enhancement with inflammation around. The one thing you've got to beware of in these patients is if they've had positive lymph nodes removed, then that can be a sign of recurrent tumor. Endometriosis is a very common reason for an inflammatory mass. Basically, patients get this irregular discoloration that's recognized at laparoscopy because you've got menstrual shedding with an inflammatory reaction that's spread throughout the peritoneal cavity. You've got entrapped debris that make it this blue-black appearance, and over time it becomes devascularized and scarred, leaving you with a white plaque. There are a couple of theories about why endometriosis occurs. One is the commonest is the retrograde menstruation theory, i.e. endometrium spills retrogradely into the peritoneal cavity, while other people believe that you get metaplasia that is multifocal within the peritoneum itself. Either way, what you get is these complex, cystic, and solid masses in the peritoneal cavity. Often they're associated with uterine adenomyosis, this irregular junctional zone thickening. But classically, the adnexal masses that occur with endometriomas have got these shaded heterogeneous masses that are high in signal on the T1 weighted image, low in signal on the T2 weighted image, as you see here. This is a STIR image, so it's basically a FATSAT T2 weighted image. This shaded shadowing, which is very classical for hemorrhage because of the endometrioma from blood products. Moving to the revised WHO classification of ovarian tumors, if you remember nothing else from this talk, this is the bit to remember. There are really three categories: the epithelial tumors, the sex cord-stromal tumors, and the germ cell tumors. And of those three categories, the epithelial are by far the commonest. So they arise from the surface epithelium, and they come in a variety of serous, mucinous, endometrioid, clear cell, and Brenner varieties. You don't necessarily have to remember all this, but surface epithelial tumors is all you have to remember, and they can be benign or malignant. Those are mostly the cystic tumors. The other two, which I said are less common, the sex cord-stromal tumors are solid, and the germ cell tumors are solid. And they also come in benign and malignant varieties. You don't have to remember all these. You can look them up anytime, but just remember the three main categories: epithelial, sex cord-stromal, germ cell. And of course, you can get metastases to the ovary. So I'm going to deal with those three categories in the benign and malignant classes. And to start with the benign, the epithelial benign ovarian tumors are the commonest. They form 60% of serous ovarian tumors. They're basically large, simple cysts. They're in women of sort of middle years, unilocular or multilocular. The important thing is papillary projections are absent. That's a serous one. This is a mucinous one. It doesn't really make a difference. Basically, they look like cysts. They're hypointense on T1, hyperintense on T2, and you can get some enhancement of the cyst wall. Sometimes they're complex, and you can get them in conjunction with fibromas. This looks just like a fibroid. It's well-defined, very dark, homogeneous on a T2-weighted signal. This is a cystadenofibroما. And then the rarer type of epithelial tumor is the Brenner tumor. This is in older women. The reason it's an epithelial tumor is it basically contains urothelial-like elements within it and a fibrous stroma, and it is solid and sometimes bilateral. And this was a very good pickup from one of my colleagues showing this sort of solid bilateral small masses in a postmenopausal woman with the restriction on the diffusion-weighted image. Okay, so that's the epithelial benign. Now, the sex cord-stromal benign are the fibromas. They look just like fibroids, well-defined, low signal intensity on T2-weighted image, and you can get heterogeneous enhancement with gadolinium. But it's their sort of low signal intensity, well-defined nature that really defines them. The second kind of benign sex cord tumor is the thecoma. These, again, are well-defined, low signal intensity, but not quite as low as the fibromas. They're sort of a kind of intermediate shade of gray, and they often have these sort of cystic lakes within them. They often secrete estrogen, so the patient becomes estrogenized, and there's the classic Meigs syndrome when they're associated with pleural effusions. But the appearance is fairly classical, and you will be able to recognize them. Here's another case just to show you that on diffusion-weighted imaging, they're homogeneous and restricted on the ADC map, as you see there, and that they enhance evenly. And then the third type of benign sex cord-stromal tumor is the Sertoli-Leydig. Again, this is a rare tumor type, but it's in a young patient. Again, very well defined, intermediate signal intensity. The patient's age is a giveaway here, and the other thing is they produce testosterone, so the patient becomes progressively masculinized. So it is the hormonal thing about the patient that gives it away that it's a Sertoli-Leydig. And then the commonest benign tumors are really the germ cell tumors, and these are, you're all familiar with, the dermoid cysts and the mature cystic ovarian teratomas. There is a pathological difference between them in that the dermoids only contain dermal and epidermal elements, whereas the mature cystic teratomas contain mesodermal and endodermal elements, and people kind of use them interchangeably, but the pathologists recognize the difference. Again, here, fat is pathognomonic. If you see fat within a tumor, it is a germ cell tumor, it is a dermoid or a mature cystic teratoma. And the fat suppression techniques need to be done. So where are we with the benign ovarian tumors? Basically, cystic are epithelial, solid without fat are the sex cord tumors, solid with fat are the germ cell tumors. T2-weighted imaging is mandatory. Diffusion-weighted imaging is pretty, but doesn't really help. And gadolinium is used just to exclude the presence of enhancing nodules within the cystic ones. So, malignant tumors, these are the ones obviously you don't want to miss, and the ones that you're unlikely to miss because they're so characteristic. They're often large masses, multiseptated, nodules and projections within them, diffusion restriction, as you see here. They're complex cystic masses that must be considered malignant, and they are basically in middle-aged women of 6th and 7th decade, and they have this appearance of high on T2 with low on T1 on the cystic components together with the solid components, as I said. Here are just some pretty examples showing you the papillary form projections and the kind of complex heterogeneous pattern of the solid components that characterize them. This one just shows an endometrioid cancer, and again, the only point here is that on diffusion-weighted imaging, the solid components are restricted, and they enhance on the gadolinium-enhanced images. An important category not to miss here is the borderline tumors, and the reason these are sort of slightly different is that they're probably less invasive and therefore require less aggressive treatment. And the only way to really recognize them is that they have less nodules, often smaller nodules, as in this stippled appearance in this benign, in this borderline tumor, but they can be spread all over the peritoneum, and they can be recurrent. So if in doubt, always call it a malignant tumor rather than a borderline tumor, unless you're sure or there's just very few nodules. Okay, so that's the malignant epithelial. So the second category is the malignant sex cord-stromal tumors, and here we have the granulosa cell tumors. Just like the thecomas, they're this intermediate, homogeneous signal intensity with these lakes of high signal cystic areas within them. So just think of a thecoma and a granulosa cell tumor kind of in the same spectrum, but the difference with the granulosa cell tumors, obviously, because they're malignant, they're multiple nodules, they're not just solitary as a thecoma, and they can be really quite aggressive. But they go on, some of these go on for years. You know, they have multiple chemotherapies, multiple surgeries to remove different nodules in different places, but they're highly symptomatic to the patient. So actually, giving the surgeons or the oncologists an idea of exactly the extent of these masses is very, very helpful with MRI. And then the malignant germ cell tumors are really tumors of young people, often even in a pediatric population. They're immature, and you can see here they've got multiple elements within them, often calcification, mucinous elements, fat, sebaceous material, and so you can see them as heterogeneous masses in the adnexal. If you get a malignant germ cell tumor in an older person, it's often a dermoid or a mature cystic teratoma gone bad. And it's the squamous elements of those tumors that go bad. And you see here, it's clearly a dermoid because there's a fat fluid level. But this solid component is irregular, it's nasty looking, it enhances, and these are really very aggressive tumors that metastasize early and the patients do badly, so it's quite useful to recognize them. And then finally, obviously, you can get metastases to the ovary. Again, they're often bilateral. There is often a history of other malignancy, often gastric or other GI malignancy or breast. And the clinical history is really definitive. And this just to show you on the diffusion-weighted image, these highly restricted, irregular masses in both ovaries. So summarizing the malignant ovarian tumors, again, the T2-weighted imaging is mandatory. The epithelial ones are cystic with no solid components. The other two, the sex cord-stromal and the germ cell, are often completely solid. And gadolinium enhancement, again, is mandatory because it shows the enhancement and the malignant extent of the tumor. So in the final few minutes, I'm going to talk about staging malignant tumors. Well, now that we've characterized our adnexal mass, we want to know exactly how advanced it is, because it the staging influences the management pathway. So for ovarian cancer, the management pathway is a patient often presents late, sadly, because there's no screening. CT is the imaging modality of choice, and the treatment is either by primary surgical debulking, i.e. surgery up front, or delayed debulking, which means giving neoadjuvant chemotherapy, followed by surgery after 3 cycles, and then some more chemotherapy. So where does MRI fit into that pathway if CT does this so effectively? And then obviously after they've had that treatment, there is an imaging follow-up because it recurs, it's late disease, and where does MRI fit in the follow-up? So to detect, as I said, CT, why use MRI? Basically, the contrast is better. You can not really see the tumor here, but you can see it very easily with MRI because of the higher contrast against the bowel wall. Again, we've talked about contrast enhancement and doing dynamic contrast enhancement to get quantification, and we can do this to look at the extent of masses, get values such as the K-trans and the extravascular extracellular space volume measurements that can tell us something about the aggressiveness of the tumor. On diffusion-weighted imaging, as we apply increasing diffusion weighting, we can see that the ascites, which accompanies this disease, and it's really pathognomonic of this disease, the signal from the ascites diffuses away, the signal from the extensive peritoneal disease is retained, and we get this beautiful contrast of the extent of this ovarian plaque throughout the abdomen and pelvis, and can quantify the tumor burden and its exact location. And we can also get numerical values from the ADC in the peritoneum. The staging accuracy is 91% compared to that of CT or even PET, so I would say that diffusion-weighted imaging is really quite a useful modality here because you can use it to actually locate disease against the bowel wall, because that is where the disease occurs, on the peritoneal surfaces of the bowel wall, and you can do these color-coded maps, as Avis has shown you before. So the skeptics among you, or the cost-conscious among you, can be saying, well, why do that? You can look at this and say, oh, well, there's advanced disease here. We can give the chemotherapy and then see how the patient has done. But in a case like this, for example, you might want to say, well, is this mass, cystic mass, a malignant mass in the first place? And if so, what stage is it? And so that's where the MRI really comes into play. The contrast-enhanced imaging you can use, as I say, in a semi-quantitative way to look at, say, how quickly, how extensively the contrast is uptaken, the amplitude of the contrast enhancement, how quickly it's uptaken, so the time it takes to reach half the maximum value, and the slope of the enhancement, how briskly it enhances, and all those are characteristic of malignancy compared to benign disease and can be used to differentiate the two. And here's some nice examples, some from Avis's work, looking at this contrast enhancement for the detection of the tumor and also for looking at the extent within the mesentery. The diffusion-weighted imaging also shows the extent of these plaques here, and the two important points I want to make here is not just about detection accuracy, but never use the diffusion-weighted imaging on its own, because on its own, it is not that helpful. It is as helpful as T2-weighted imaging, but the power of the diffusion-weighted imaging is really when you use it in conjunction with the T2-weighted imaging. And the other point I want to make here is that there is also a site-specific variation in the accuracy of diffusion-weighted imaging, because just like CT, there are areas that are not so good, such as on the liver surface, high up on the liver surface. Unfortunately, this is an area that's actually very critical surgically, because at surgery, they try to get a complete resection, what they call an R0 resection, where there is no macroscopic visible disease. And it is up on this liver surface that we want to be most accurate to help our surgical colleagues. But in any event, it always does better than CT. So it's better to use diffusion-weighted imaging than CT if we want to precisely locate disease. And then finally, in treatment response monitoring, with ovarian cancer, we have a very good biochemical blood marker, the CA125. And our oncology colleagues will say to us, well, why do you want to use all these fancy and expensive imaging techniques? It's because, in fact, we can tell at an earlier time than the CA125 response that there is a response to chemotherapy with these patients. So you can see that the increase in the ADC occurs after one cycle, whereas in non-responders, there's no such increase. So we've got an early biomarker, but the important thing is also you can look at different disease sites and say one site is responding whereas another is not. In treatment-naive disease, it's not so important, but often these patients come from multiple courses of chemotherapy because they recur, and in relapsed patients, being able to tell that one particular site is a non-responding site may be helpful if the surgeons can go in and do a secondary debulking. And because it is such a quantitative technique, you can draw a region of interest around the entire tumor burden or the particular lesion that you're interested in and get a distribution of ADC and follow that through chemotherapy. And you can see here that as the chemotherapy is working, in a responding patient, you will get a shift of the ADC to the right, whereas in a non-responding patient or a non-responding lesion, there is no change in the ADC. So with that, I just want to summarize. MRI is useful in the characterization of adnexal masses. When used in conjunction with the clinical presentation, it can distinguish inflammatory from tumor masses. The inflammatory masses, the patients are always sick. T2-weighted imaging alone is useful in describing benign masses. You don't necessarily need any fancy techniques, but if you're concerned about malignancy, gadolinium enhancement is mandatory. Complex masses should always be considered malignant, and surgery is the definitive treatment in all cases. Where malignancy is likely and you're doing staging, diffusion-weighted MRI is a very useful adjunct, but use it in conjunction with the T2-weighted imaging, and you can use it as a quantitative technique for response assessment to neoadjuvant chemotherapy. With that, I'd just like to thank my amazing teams that I work with and our funders, and thank you for your attention.